Hey everybody, again, Michael Ifkovitz. Everybody calls me Ifky. Please feel free to do so. Normally it's because there's like half a dozen mics on any given call. Could probably go through the list here and catch about a dozen. Director of Business Design here at Method, been here about 4 years. Prior to that, I spent a lot of time in the healthcare innovation space, and happy to say that much has changed, but also a lot hasn't. And that's a bit about what we're going to be chatting about today is the appreciation of the complexities of innovating the patient experience in those healthcare settings. We've brought together a awesome group of panelists here that I'll have introduced in just a moment, but it's to help get an appreciation for the different points of view that all need to be considered across that healthcare equation, from the physician side of the house, the health system side of the house, the folks leading digital innovation strategy experience efforts, the nursing side of the house, the patient experience and their point of view. All of these things are a confluence that needs to be considered as you're trying to innovate. And so we're going to have some experts talk about their experiences doing that, what we need to have in play in order to be successful at it, what is kind of preventing some of these things from happening, and how we make sure that the patient care experience is paramount to the entire thing. So with that, I'm going to stop talking as much and leave it to our panelists to get started. Amber, you're first on my screen, so I'll let you go first.
Hi, good afternoon or good morning. It's very nice to be here with you guys this afternoon. My name is Amber Fensel. I'm the Vice President of Digital Health and Engagement for Novant Health. We are in the Carolinas. I have the responsibility for delivering clinical care with a dedicated team in an on-demand or scheduled video setting. And I also have the responsibility for patient experience, patient engagement when it comes to digital experiences for Novant Health. And then also delivering digital tools, whether it be inside of the four walls to enhance an experience or a clinical setting, or perhaps delivering traditional healthcare, but outside the four walls in a non-traditional setting.
Awesome, thank you. Thanks for being with us. Bridget, go ahead. Dr. Weefling, go ahead and say hello.
Thanks. My name's Dr. Bridget Weakling. I'm an internal medicine and pediatric physician. I'm the executive vice president at Rochester Regional Health, in charge of the physician enterprise and care transformation. We oversee in our area the ambulatory footprint, so to speak, and our digital strategy for patient engagement, how we help provide tools to the providers so that they can better and more efficiently manage their patients and adapt to an ever-changing digital world.
Awesome, thank you. Anne-Marie?
Hi, I'm happy to be here with you all today. I'm Marie Watkins. I am the Vice President for National Patient Care Services, Strategy and Operations at Kaiser Permanente. I've been a registered nurse for over 35 years, and about 25 of those have been in a chief nurse role. In my current role at Kaiser Permanente, I'm responsible for overseeing the national nursing strategy. And within that strategy, we have many initiatives around care experience, care delivery technology optimization, especially for nursing workflows, obviously quality and patient and worker safety, our workforce, and then research and evidence-based practice. So I'm very happy to be with you all today. Thank you.
Awesome. Yeah, well, let's just get right into it. There's a lot of what you're all doing touch on a digital aspect in some capacity or another. So Amber, what would you say are some of the most common ingredients you need to successfully innovate and deploy new products and services within a setting as complex as healthcare?
There's a few key aspects I would highlight. One that I do think is material and would be a call to action for folks listening is to gain organizational alignment, not only from grassroots and having the right talent and subject matter experts for that design and development stages, but having innovation as a priority from the top down. So having that alignment where you're executives and senior leaders are focused and investing in an innovative and digital experience for the patients, but also for the provider. So I do think that it comes from top and from bottom to be successful. I would also suggest to know what your core strengths and strategies are, and then be open to partnering. Perhaps one scenario may call for a build that's internal. You've got the talent to do it and the capacity. Another solution could be something that's co-development, where it's you and perhaps a startup, and they have strengths that you don't, and be open to that partnership. And I do think that great things can come to life in that sweet spot if you can find a partner that embraces the same vision and culture that you have, and you have similar missions, but their strengths complement maybe areas that you don't have, and you can come together to do something really, really great.
Yeah, that's awesome. Looking beyond your four walls to see where you can kind of shore yourself up and get a hand up in there. Dr. Wiefling, from the physician perspective, it sounds like you're getting tools into the hands of the doctors to also help with their patients. Talk about what it is that's needed in place to bring those things to life and move it beyond prototype and beyond just theoretical.
Yeah, thanks. So Rochester Regional Health, we're a pretty large integrated delivery network. So we're 3.5 billion. And we have rural, urban, super rural, and suburban. And so we have providers that are in all different environments and with access to all different types of resources in their own communities. And that reflects with their patients, right? So I think Amber hit the nail on the head on so much of it, right? From the standpoint of it is both, right? It's bottom up, it's top down, and it's also, I say, top down from the standpoint of it's really important for the organization to have a full strategy and not just to be sort of enamored by the one-off, oh, this is a bright shiny object that looks amazingly cool, we're going to throw this in, right? But to really think about holistically, where do we need to take things, and not to try to implement too much, but to be able to really share the vision, share the strategy, so that the rest of the team can come along. And providers are great partners and terrible employees. So if you partner with them on really laying out the strategy, then you're not sort of in a place where you're feeling like you're having to shove it into their practices, which they definitely don't appreciate. And neither do the patients, because the patients take almost as much time as the physicians do to try to adapt to new technology. And so vision, important, strategy roadmap, important, set from the top. But then also you have to have the bottom-up approach from the standpoint of design and implementation, and really getting the feedback from the boots on the ground to understand, you know, we have a lot of broadband issues in our rural areas. And so some of the really cool technology that we want to implement just really isn't possible in those areas. And it's too choppy, and it creates an experience that's not effective. And so those are not areas where we typically try to push in. Also, certain kinds of populations, right? It's just not amenable. And I think we all went through this, right, during the massive switch during COVID to telehealth, when lots of organizations around the country were sort of foisted into it and really didn't have time to plan. We were pretty fortunate. We had already had a roadmap, and we're pretty advanced in our roadmap. So flipping the switch for us was much easier, but did not envy a lot of those folks who weren't. The other thing is when you think about your steering team, you got to think broader than just your clinicians. You really have to think about all the different aspects of who touches the patient experience, because digital will impact them. So when you think about billing, and you think about the front desk, and you think about the website and the design of the website and how you're going to market it, so that steering team being broad. We're also on Epic, and we're fully integrated with Epic. So that means that whatever we put in place in our system is going to be felt by everyone. So you also have to think about, how does this impact primary care versus specialty care versus acute or long term. And so it's not easy to launch something, you know, big. So we've taken the tactic, especially one of the great successes we had during COVID was we used the same kind of principles, but we microed it down. And we did sort of an initial quick quick pilot with a technology that we wanted to use. It was a partnership. We decided let's partner, not build ourselves. So, and that went really well. So we co-developed, and we were able to be pretty nimble with a smaller group. And then we were able to say, okay, here's what we learned in the first 5 days. Let's pull on a whole bunch of other people now, understanding how to expand it. So that sort of pilot and push and expand was a great opportunity too, I think, when you're dealing with trying to move rapidly.
Absolutely. Absolutely. Dr. Watkins, it seems like we've touched on organizational alignment and managing attention between grassroots and top down. Can you talk to us a bit about how you're managing that at Kaiser and kind of bringing those two together?
Yeah, and just to echo a little bit of what Amber and Bridget said is, I think it goes back to the human-centered design approach and really looking at the problem you're trying to solve and not falling. That shiny object is the perfect analogy of this great system or tool that's going to help, but then you're not looking at what's the problem we're really trying to solve. And then you end up with issues where things don't integrate together. We're also on Epic. And so that's always the first question asked is, does it integrate with Epic? Because if it doesn't, then we're creating standalone systems and we're having to always go back and work on those interfaces. So that's kind of the overarching piece I would focus on there, and that's what we try to do. I think the other thing too is it is important that you, I think it's the famous quote by John Wooten about you hurry but don't rush. So you don't want to be doing pilots for 6 months to a year that just take up lots of resources and energy. You want to do those small tests of change and then have that planned expansion like Bridget was referring to. And then I think probably one of the most important things too is when you're looking at deployment and getting things set up, you have to look at the back end too. How are the operators going to be supported? Do they have the resources? Because one of the worst things that can happen is we introduce a piece of technology or a workflow supported by technology, and it's not used. It just sits there. It's not in the clinician's workflow. And if we don't build in those supports and look at the barriers to adoption and putting it into their daily workflows, it doesn't add value. So those are just some of the additional things that I would add.
That's it's leading to a great segue to the second question, but I want to dig in a little bit around something everyone kind of touched on is that, a lot of times, and we talked about this when we were first discussing the panel a couple of weeks ago, but it's the healthcare experience is so much more than just care provider and patient. There's support staff, there's clinical staff, there's administration staff on the hospital side. There's also caregivers and loved ones and families that are impacted by this experience as well. When designing pilots or searching for new tools that could be brought in from a digital setting, how do we go through, or how do you go through and make sure all of those folks can be included or accounted for? Because it's a giant stakeholder map. And Amber, I'll let you go. I want you to go first.
That is a great question. And often I think the right way to go about it may not always be the most popular choice. And that is to do what Method does so well, and is to pause and focus on that human experience, as Dr. Watkins mentioned. And you really have to step out and up to think about what is the problem to solve, and how might the patient and the provider walk on that journey together. So I think that there's a design element that we often, in a sense of urgency or trying to quickly solve a problem, may overlook. And so I think that is a muscle we should all challenge ourselves to flex and to be more intentional about that step in the process, and also recognize that you can iterate that step as well. I completely agree with the notions of prototyping and learning and iterating and moving forward when you are trying to do something new. But it is extremely important to also know your community and your population, and to know the know the level of acceptance and maybe even exhaustion of your clinicians, because that also has an impact to what they may be willing on both fronts, both stakeholders, to accommodate. And their influence as a patient and a provider will cascade to the caregivers. It will cascade to the clinic administrators. And if we design a great patient experience and it's bright and shiny and it suits a need that our patients have expressed, through research and through feedback, but our clinicians aren't able to adopt it, they weren't brought along for that buy-in, like Dr. Weefling mentioned, and the workflow isn't cohesive with the ability to deliver the care in which they're responsible for delivering it, then it won't be adopted. A patient won't get to experience it to the level in which you intended because you've missed that mark there. So there's really, in my mind, some intentional planning and design work when you think about the core stakeholders, the core actors, if you will, not just the stakeholders for the project, but the actors that are going to be a part of that experience.
There's a couple threads that I'm going to kind of pull together as a follow-up, and you touched on I love the sentiment of not just provider acceptance but provider exhaustion. It's probably a bit of that SOS shiny object syndrome that Dr. Weefling put out there, and I think there's a common theme I heard is bringing folks along and for the journey, but it's also we don't want to overwhelm them. So every new idea that comes down into the portfolio, we probably can't go taking to a physician panel or a nurse panel or a patient panel for reaction. There's probably some work in massaging that needs to be done before you get it to that point. And so, Dr. Weefling, how does your organization, Rochester, know when it's time to move the ball forward and start getting folks involved?
Yeah, so we follow a lot of the data. And, we're in a pretty competitive marketplace. So we're also looking at, what's the competition look like, and not just from the other providers in the market, but from venture. We are pretty heavily universitied area. We have the most colleges and universities per square mile in anywhere in the country, which is something that most people don't think about. So we have a lot of startups and a lot of technology that's sort of flooding the area. So we pay a lot of attention to data and what's happening in the marketplace. We educate our providers on a regular basis about what's changing, what's new, what's happening in nationwide, so that they're not surprised by some of these trends, and that they're actually thinking about how, physicians are competitive, and so they want to win and they want to be part of the game. And so I like to engage that part of them in trying to think about the strategic plan. And then I always, I promise them that I won't implement anything with them that I wouldn't implement on myself. So I think it's important that the physician leaders actually practice and are able to, roll up their sleeves and really feel and understand it, because that helps with credibility as far as not implementing things that are going to be overburdensome, because I think Amber is absolutely correct. And for instance, right now, it's a very tough time to be asking people to do one more thing. From COVID has really decimated the national workforce. We went into 2018 with projected shortages across the country. We've lost 500,000 more. A whole bunch of our pipeline just evaporated, and that's not just providers; that's nurses and allied health and people just saying, you know what, I'm going to sit out healthcare right now, so I'm not even going to jump in the game. So we're projecting 18 million healthcare worker deficit by 2030, and so we're feeling that, and we have to be very choosy. And so the things that we're currently focused on are things that are going to make it easier for the provider to have a relationship with their patient, and make it easier for the patients to have a relationship with their provider, because if we can make the experience of healthcare a little smoother for everybody, it's a load off rather than a load on. But it's a delicate balance.
Yeah, it's I think one of the promises of a lot of the digital tools in the market, a lot of things that are coming out are trying to offset some of the burden on current providers and maybe scale up others. There's Dr. Watkins, would love to hear what are other barriers that we need to kind of remove or work around to kind of reach the promise of a lot of these digital health tools. Scanning the landscape, $29.1 billion was invested into startups and early stage digital health companies in 2021. There's a lot more similar investment in the years prior. Not sure if that promise is being fulfilled or met just yet. So what are thoughts around getting those things into the system or using those tools?
I think that's part of the challenge. Is there's so much out there. Every time you turn around, there's something new with a wearable or an app, and then it goes back to that question of how will it be used? How is that information secure? How is it protected? Is it how accurate is it? There's lots of functionality that comes with our Apple Watches, and there's stories where they've saved lives because they've detected arrhythmias or falls or things. And I think we need to continue to leverage that because that really is where the future is going. But it has to be with so many seems like entrants coming in all the time. It's how do you manage that? And it goes back to the question of integration. So at Kaiser Permanente, we're looking at, okay, this is a great product from whomever. How does it work with our EMR? How does it work with remote patient monitoring? Where can we integrate that into our workflows? And the challenge is you have to do that pretty quickly because things, again, are moving so fast. So I think it's kind of the sheer overload of all that. But there's another, when you were talking about barriers, the other thing that I think that's really important to call out is on the patient side, when we're all really looking more at social determinants of health, and do they have food? Do they have access to their medication? Simple things, shelter, where do they live? Who lives with them? All those kinds of things. And the one that's probably even more important, and it came about when all the kids were doing homeschooling, and it's that access to technology. And do they have access to that? Because again, we can develop all these tools and apps, but if they don't have access to it or they don't understand how to use it, they won't, and we lose that benefit. So that's really something that needs to be continued to brought up, that access to technology as we continue to advance is an important piece of the social determinants of health, because that is going to how I imagine we're going to continue to keep delivering healthcare. So that I always try to kind of bring that forward because that's not usually one of the ones when we think about Maslow's hierarchy. And then I think the other thing from the patient view is the patient expectations. And I was reading something the other day that as we've all advanced to telehealth and virtual visits, in the past, in general, a patient might be fine with waiting 30 minutes in the waiting room. But now they get on to do their video visit and they're waiting 7 minutes for the provider to come on, and that's not acceptable. I want it on demand. And we're going to have to really continue to work with our clinicians and providers and other team members on how we meet that demand need so that patients don't perceive that they're still waiting.
Yeah, it's interesting that you bring up the social determinants because we have, we've got a large population of Medicaid lives and run several FQHCs in our footprint. And so one of the things that we did specifically with our TITO technology, which we're in the process of rolling out as we speak, and we got some grant money to make sure that we were able to purchase the units for the patients, and we handed them out. So we didn't expect them to get them and have them. And that was really well received by the patients. Certainly it was an expensive endeavor, but we believe that the return on investment from the standpoint of our population health contracts will exceed our investment. So that's another strategy.
We too are a TITO Care partner here at Novant Health, and that would be a great example of identifying a partner to meet a need that you can join forces and extend the access and use absolutely options such as grants and donor funding sources to get the technology further into your population. I think the research and the intimate knowledge through data and through relationships and being a part of the community to know your community and understand that population is also very key, so that you can begin to design an experience and to identify solutions that fit your populations. Not every new capability and new product that's on the market is suitable for all populations. And so I think as a system, it's extremely important to use data and to use community relationships to know your rural and your urban populations, as you mentioned. And for those who are part of the technology vendors who are coming into the marketplace, I think it is also prudent for you guys to understand of your clients, your customers, and your prospects where your technology may or may not make sense. That shows the desire to be informed and to be invested in the systems that you are speaking with, courting, or potentially partnering with as well.
Mm-hmm. It really comes back to that human-centered design element, and who are you trying to work with, the community that they're in and their situation, and really understanding that before you try to implement a solution. It doesn't always have to be an app. It could be a timely phone call. I know that there's tropes out there about fax machines being in doctors' offices, but it's lowest common denominator of communication. It kind of needs to be there. Anne Marie and I were joking about there's no target market for healthcare. If you want to deliver through an app and say, oh, somebody doesn't use the app, they're not the target market. Well, you don't really get to do that when it comes to healthcare and communications. It's a lot to balance. And at the end of the day, there's a patient and a family that's expecting incredible care, timely care. How does that stay central to everything that we're doing?
I can take a stab and kick us off.
Yeah.
I would reiterate knowing and understanding your patient, but there is technology and innovation is intended to solve a problem, enhance, optimize, create opportunities. It is not intended to replace the personal relationship that at the end of the day, I believe is essential still in healthcare. And technology can create a great experience, a great enabler for the humans that are a part of that journey. But through all of the digital capabilities that I have personally implemented here at Novant, when we think about our conversational chatbots and voice bots and self-serve tools that we have created, and all of those channels, there is still indication from the patient, the user, that they want access to a person when they decide that they want access to the person. Is it a phone call? Is it a live web chat? And so although technology and innovation is my job all day, every day, I still believe that we have to make it available, make the human available for that patient or that caretaker to get access to at the point in time that they want it. So that's meeting them where they are. And therefore the spectrum of tools and the access that you are providing them also, I think, has to range to meet that wide variety of patients and consumers that you are serving. So it can't be one solution, it has to be a multitude. And you always have to remember to make a professional available to them in some manner through that digital channel, so that if the need arises and they want to speak to that human, you're still making that available to them.
Yeah, we invested in a large, what we call our communication center, and it's really sort of our air traffic control for a lot of our digital care, and utilizing the technology that we put in place just in the communication center to be able to track how we're doing in our performance, and really adhering to a dashboard and setting some metrics and goals that we're paying attention to. as far as, I think Dr. Watkins, your example of, the wait time and the 7 minutes in the waiting room really is not acceptable anymore, right? And so tracking, disconnect times. So we have some technology that allows us to, really get granular in some of that area, and that's been helpful. It doesn't mean we're always hitting it, but at least we know where we're going, and we know where our blind spots are. So I think being able to think about how are you going to measure what you're doing and how are you going to measure it, from different aspects was important. I think that is something we learned over time, which is why we put the communication center in. We also grew really fast, and so we needed a way of linking our offices together so that they could be stronger and we could be more efficient. So that was a sort of a lucky but good move that we made quite a while ago that really did well for us during COVID, certainly. But I think that's one, and I think you got to pay attention to your patient surveys. So we do, they are, rudimentary from the standpoint of they are paper and they are mailed, and some people fill them out and some people don't. But generally, people that are filling them out have something to say. And so that we actually do take that data pretty seriously. And so we're CG caps, which is I think what most people are in the ambulatory, and HCAPs in the acute care. So utilizing that data and giving it to our clinicians and giving it to our nurses and talking about how we can improve it and talking about what are the tools that we have available to us to try to improve some of those areas and targeting one or two things each year. So we do that. We tie it for the physicians, we tie it to compensation. So that makes sure that we keep it at the forefront if there are big things we need to move, because we really understand how important the patient experience is going to be for us in a really competitive market. So those are things. We also have several in different areas, because we do have our FQHCs. We have a lot of patient boards. And so those patient boards give us a lot of feedback. And so that is very valuable, because they're empowered and they're vocal and they have good ideas, and they don't understand the healthcare space, so to speak, from the standpoint of the intricacies of it. They really do only understand the experience and the expectation. And so for us, as frustrating as that can be, excuse me, because sometimes we're like, well, you can't do that. We're not set up that way, and you want to kind of argue your point, and then you have to kind of step back and go like, wait a minute, it doesn't really matter if I'm right. If I can't get them there, then it doesn't work.
Right. Everybody has to be aligned on it.
Yeah, so that's been really helpful for us, for sure.
If I could build on that just a little bit, I think, in our telehealth strategy, similarly, one of the things that we're looking at for outcomes in terms of patient quality is getting all that data we can harvest from our EMR and looking at where we can do some comparisons of outcomes, simple outcomes, like how we manage pharyngitis face-to-face versus telehealth, and really starting to look to see, are there any differences in terms of the care outcomes? And that's one aspect of, obviously patient care. And the other aspect is the care experience. And here's where the kind of the policy aspect comes in, because in our HCAPs and our CAP surveys, they aren't designed for virtual care. And so how do we have survey questions, whether it's a separate survey or whatever that's going to look like? I think everybody's kind of doing their homegrown right now. But at some point, we're going to have to be able to measure from the patient perspective, was it easy to log on? Did you have any problems with downloading the app? All those things that we just haven't really been in our wheelhouse necessarily on the forefront to ask those questions. So I think that's a piece that's going to need to be revisited. And then the bigger picture, which we can't solve ourselves, but we need to be having those conversations and amplify those voices, is on the reimbursement side, because as we develop all these new and effective ways to deliver care, how are providers and systems going to be reimbursed for that care? And that's I think going to slow us down if we can't figure out what that's going to look like in the future.
I'm glad you touched on that. And I think it's been highlighted a couple of times with the Tito technology rollouts and getting population health management contracts on board with that. This is going to be incredible elementary view of it, but idea beat up technology concept, physician buy-in, and potential rollout, maybe pilot, is that when you then go to a payer to discuss either altering or restructuring any type of reimbursement?
So I can speak to that because that's a lot of what my job is. So I am frequently in front of them first, talking to the payer about the need and the case, and then trying to, warm them up to pilot results and how it impacts them and it impacts the population. And I will tell you, the population health contracts are not the end all be all win. From the standpoint of, one of the things that it does do is it gives the payers an out to say, well, if you save money, you get it back. But that doesn't actually work all the time with the reinvestment from wins and it also doesn't allow for any of the upfront cash investments that are needed. So that's always kind of a dance. And so I have found that committing to small pilots after I've built a case for need with the payers has gone better. And then we are meeting on an every other month basis on the data. We spend a lot of time upfront, a frustratingly amount of time upfront, agreeing on what is going to be measured to determine whether or not there's success. And I will say that some payers are much better at getting that data. You would think that they would be, a lot of them are rolling in the money. You think they'd have better data systems, but they just don't. And so now that we have Epic and we've got BI tools and we've got the data warehouses and things, we tend to have even better data than they do. But being able to spend that time, as frustrating as it is up front, to make sure that you're getting an agreement on what's going to get measured so that you can build your case at the end is really important. And that includes cohorts, comparing cohorts, right? You really got to get down into the details around what are the disease characteristics and patient characteristics that are in the control cohort versus the cohort that you're choosing to do the intervention on. So that stuff actually, can bite you in the butt if you don't get that right. So we spend a lot of time up front in planning. We don't just usually launch and go. However, I will say that in some of the areas where we know that we need to do it, and it really, the payment mechanism is already there, and it's just a strategy that we have to embark on. And TITO was one of those. I mean, there's already a mechanism for getting paid. It did take a long time for our payers in this region to get there, to pay for those kinds of services, but they do. And so as soon as that was kind of aligned with the technology being good enough that we actually felt it could deliver on a good experience, then we launched forward with driving it. We didn't do a pilot with the payers.
Awesome. Yeah, so if the evidence presents itself, just move forward, start chasing it down, and then others will eventually follow as needed. So awesome. Well, I've got one more quick question, and then we've got a couple in the Q&A that we'll run through. I'm just curious that we talked about there's obviously headwinds and tailwinds from the pandemic and COVID. We talked about impact on provider shortages and caregivers, nursing shortages and things of that nature. But I feel like it did potentially help accelerate some digital health and virtual care endeavors. Are there any other headwinds you could think of towards the healthcare system, either as helping to work through barriers or around barriers or bringing attention to certain aspects? Amber,
I think from my perspective, the patients got exposed, right? So it was like the one time, I feel like in a long time, where the providers had a mandate and the patients had a mandate. And the mandate for the patients was stay home.
Yeah.
And the mandate from the providers was stay home. Keep the patients home. So figure out how to work together to achieve those goals. And so that really helped, that sort of social mandate that we had to overcome, barriers to care, allowed us to have a lot of headwinds. So it wasn't, it was kind of perfect because the technologies were there, the social driver was there, and the payers were certainly there. So we were very lucky, I think, as a nation, that happened in that way. because I think if the technology hadn't been there, it would have been a disaster. I think if the payers hadn't been there, it would have been a disaster. And so it's really worked out. It really worked out. I think we got lucky.
It kind of forced all that the cross function that you desire to have. It just kind of forced it. Amber, did you have a similar experience at Novant? Is there anything in particular that was able to move forward faster? Is not the right word, but it's the word I'll use right now.
Yeah. Oh my gosh. Yes. We at Novant we were the second in the nation to go live with video visits in Epic back in 2013. So from 2013 to 2020, we had a total of maybe 2,400 video visits. So super small. Since March of 2020, we've had over 1 million. So if there was something good to come out of COVID, I would say catapulted healthcare and the acceptance of technology and digital health light years ahead of the pace at which we were previously moving at. So that has been at least one good to come out of that bad situation, the bad situation. But the pandemic really just charted a new normal in my mind. The challenges, as we were just touching on from a reimbursement standpoint, some of the regulations that are still trying to catch up. You know, we have some temporary means in place, but they will expire. And I think that is a reality that we have to prepare for. And I think we know what our patients and the users would prefer, and we have found this new normal. If we can just move the whole ecosystem of healthcare forward and along in the same direction, then I think the future just really looks exciting for us in digital health.
Awesome. Dr. Watkins, anything to add or what you've seen from your perspective?
Yeah, a couple things. One is just to build on what was already said, that spirit of innovation. When we were in the peak of the pandemic and family members couldn't visit, just the ingenuity that went into how can I make this work? And whereas in the past, oh my gosh, we'd never bring an iPad into a patient room. There's so many issues. It was, this is what we need to do, and this is why, and it was just more accepted. Now we're going back and making sure that everything is shipshape, we're doing it as a system, but it really inspired that ability to, I have an idea and I want to try it. And sometimes I think when we're not in that crisis state, we get caught up in, what are the regulatory issues? And not that we shouldn't, we do have to follow those, but sometimes it dampens that spirit. And then the other thing, just kind of following on what Amber was saying is, for years we've been talking about healthcare will be moving from the hospital into the home. And it's been rather slow. We're kind of all waiting for this to happen, and this also propelled us. And so, we started doing the virtual visits and the telephone visits and using things like the Care technology. And now it's really accelerated our work to kind of going back to our roots in healthcare when care was home-based and it was within the community, and the importance of public health. And so the silver lining, I think, from all this terrible things that we've been through is it's recentered us on how we need to approach this in keeping patients in their home, getting their care there, and then how are we supporting those caregivers in the home, whether it's family members, home health nurses. A home health nurse can video in now to a physician if they have a question and they're available versus, well, I got to call the physician and, they'll get back to me when they can because they're busy. And it's just opened up that whole opportunity to look at that care in the home that we've never had the opportunity before. And if we hadn't had this happen, we would be doing a lot more on the front end to get buy-in and support, and this is why. So that is probably the mixed blessing with the pandemic from my perspective.